Now they can hear us.
Okay, with your permission, I'll just do a quick introduction. Carolyn St. Charles from Health Tech. She's the Chief Clinical Officer from Health Tech. She's going to be doing the education tonight on credentialing and privileging. I actually know Carolyn from a previous phase of my life when I was in Powell. I had the good fortune to work with Carolyn. She has a bachelor's in nursing and then a master's in business. One of the most talented folks that I've worked with. So looking forward to her presentation with us tonight.
Thank
Carolyn?
you, Bill.
You're welcome.
So do you want me to go ahead and start? Are we good?
Yes, please.
Okay, so thank you for the kind words, Bill. And I'm really glad and happy to be able to do this for you, to talk about credentialing and privileging. And I do know that it's not 2024. Maybe I was just wishing it was. Anyway, next slide. Sorry, next slide.
There we go.
So this is just me. I am the Chief Clinical Officer for Health Tech, as Bill said. My contact information is also on the slide if you ever want to reach out. Next.
It's a little bit of lag, sorry.
It's okay. I'm okay if you're okay. This is just our standard disclaimer, probably doesn't really apply for this presentation, but it basically just says that you should always check primary regulatory sources. Next. All right, so I want to just talk about the differences between credentialing and privileging. So credentialing really means that an applicant to your medical staff meets the qualifications to be a member. So they are a member of your medical staff. Privileging, on the other hand, means that they have specific privileges which allows them to provide patient care. So although it's very, very rare, there are some physicians or some providers that are credentialed, but may not have clinical privileges to see patients. Next. So there's also something called payer credentialing, which is really the process of getting approval from a third-party payer so that you can bill them. And really that doesn't have anything, well, I guess loosely it does, but basically it's not the same as medical staff credentialing or medical staff privileging. Next. Okay, so both PPS hospitals and critical access hospital, which you will hopefully become someday soon, are required to be in compliance with basically the Medicare conditions of participation in order to receive Medicare and Medicaid payments. CIHQ, it also has standards for credentialing and privileging, and they pretty much follow what CMS requires. Well, to say it a different way, they do have to follow what CMS requires. And then they sometimes will have some extra requirements that CMS does not. Next. Okay, so I want to talk just a little bit about medical staff and governing board responsibilities. So I've kind of put it on a grid so it's a little easier kind of to visualize. So the medical staff is responsible for developing bylaws. Those have to be approved by the governing board. Medical staff is responsible for developing rules and regs. Again, the governing board is responsible for approving those. Medical staff determines which categories of providers are eligible candidates for appointment. So that might include physicians, might include nurse practitioners, physician's assistants, psychologists, but it's up to the medical staff to really identify those. Typically that's in the bylaws that again is approved by the governing board. Next. All right. So the medical staff is also responsible for developing criteria that must be met in order to grant privileges. So they may determine, for example, that a physician has to have a certain number of years of experience or has done a certain number of procedures, but that criteria really starts with the medical staff, and then it should be approved again by the governing board. CMS says that when you develop criteria, that it has to include at a minimum character, competence, training, experience, and judgment. So the medical staff, and I know that you have these, but the medical staff has developed privilege forms for various providers, physicians and providers. And one way that the governing board then can make sure that that criteria includes all of those things is to review the privilege forms. Then also the governing board, the CMS and CIHQ requires that fellowship or membership in a specialty body or society cannot be, the privileges cannot be dependent upon that. You can certainly use that as part of your criteria, but it cannot be solely dependent. And again, the governing board's responsibility is to review and approve the bylaws and or the privilege forms. Next. So one of the requirements that CMS and CIHQ has is that you are looking, the medical staff and the governing board needs to look at the quality of care that's provided by the medical staff. So the medical staff does that by implementing a peer review process that looks at the quality of care that's being provided. So in either the bylaws or sometimes it's in rules and regs, sometimes it's in policy, but that peer review process is outlined. That includes what will be reviewed, how often, who conducts it, and in instances where an external review is needed. So external being from someone, you may not have that specialty in-house and you need to have an external review. And again, the way that the governing board oversees the quality then is to make sure that that's a robust process and to approve that. And generally, again, it's either in the bylaws, the rules of regs, or sometimes in a policy. Next. Okay. So the medical staff then is responsible for reviewing all of the applicants to the medical staff, both initial appointment and reappointment, and then they make a recommendation to the governing board to appoint that particular provider. So the governing board is basically the final authority on whether a practitioner provider privileges are approved or not. And that's part of the fiduciary responsibility of the governing board. Next. So I want to mention just temporary privileges just real quickly. So there are some times when a immediate need comes up for a particular physician or a particular provider. And both CMS and CIHQ allow you to grant temporary privileges. Those can be approved by the chief of the medical staff and the CEO. However, there are certain things that need to be in place prior to that approval. So that includes verification of the license, a DEA number, results of the National Practitioner Data Bank. So hopefully temporary privileges are a rare occurrence. They really should only be utilized when you're waiting, when everything is in the file, everything's been checked, and you're waiting for a governing board meeting. CIHQ basically says that those temporary privileges may not be granted for more than 120 days in a calendar year. Next. Aha. Okay. So reasons that the governing board, or for that matter, the medical staff, can deny privileges, and these are pretty onerous, but things like professional misconduct, criminal background, fraudulent applications. But sometimes it comes down to the provider not having the necessary training or experience for the privileges that they would like to have. Next. Some other reasons: unprofessional conduct, substance abuse issues, failure to maintain a license, or quality of care concerns. So when the medical staff reviews the applicant, either for initial privileging or for re-credentialing, they look at all of these things and look at the applicant in detail to identify if any of these things are occurring. And sometimes that then follows with a recommendation to the governing board that we approve this provider for this type of surgical procedures, but we're not recommending for other kinds of procedures based on quality of care concerns or based on experience and education. Next. So this is the current credentialing and privileging recommendation form that I think you have that's being proposed. It's very complete. And it should give the governing board the information that they need from the medical staff in regards to that applicant, whether it be initial appointment or reappointment. Next. So the last thing I want to say is for the governing board in particular, it's important to understand the process, understand the medical staff role and your role as the governing board. But I think really it's also important to remember that if you have questions, that you should not hesitate to ask for more information and or to delay approval if you believe that to be appropriate, because really the buck stops with you. So I realized after I've gone through all of this that I really didn't include telemedicine or delegated credentialing. I thought I had a slide on that, but maybe not. So sometimes there are teleradiology, telestroke, telepsych, where the services of the physician are being provided through a telemedicine link. And that process can look a little bit different, at least in relationship to who is responsible for providing the basic data. But from the governing board perspective, it's not different. You're still required to look at the data, look at the information, and approve or not approve. So next slide, and that's all I have, but open for questions. I know that was pretty fast and brief, but any questions I can ask or answer for anyone, or any comments or thoughts? Is that a no?
I guess I would just ask one, is it pretty common, originally the board was reviewing all of those packets in full and we're trying to transition to something a little bit different. Is that pretty typical though, where, the board doesn't need to review the full package and review a summary from the medical staff?
Yes, absolutely. I would say almost all of the, maybe all of the hospitals I work with, that's their process. But I would add two important caveats. So one, the board needs to be okay with the process that the medical staff goes through to ensure that the medical staff is doing their due diligence. So that would be one. And second, the governing board, if you feel uncomfortable about a particular application or the information, then ask questions. But yes, that is a typical process.
And if I could add to that, the fact that the board has been actively involved in looking through the files has given you a unique opportunity to have
Different insight.
more complete insight than many boards have, because you see exactly what the medical staff has been reviewing. So I think our evolution has been a very good one, that the board now understands what the medical staff is doing and can rely on this summary report, knowing that the medical staff is looking at all the important stuff.
Yeah, that's
Very
true.
good point.
Very good point.
And more appreciation to them for all of that thorough review.
Mhm.
Excellent.
Yes, thank you.
So I do want to make one statement because I know that you will be translating, moving towards critical access hospital. The process is not different. So whether you're a PPS hospital or a critical access hospital, so far as medical staff credentialing, it's the same. It's really not, well, it's almost the same. Sorry about that. So there is one requirement in the CAW regs that says that you have to send out a certain number of records, physicians, not APPs, for external review. That's the only difference in the process between the two types of hospitals.
And if I could, two examples of when you might do external review. So if you have a single specialty, so say we have one general surgeon, they can't review their own files.
That's fair.
And you wouldn't have anyone else on the medical staff that would have that specialty. So you need to send them out. So that's one example. The other example is when you have two, and then they're reviewing their partner. That also is a very uncomfortable situation. So many times, if you have two of a specialty, you send out. But once you get to the three, then doing it internally is thought to be okay.
Okay.
So other, oh, sorry, go ahead.
Your statement you just made in terms of review applies in a critical access hospital to the hospitalist, does it apply to the emergency department? And I'm assuming it certainly doesn't apply to the clinic setting.
No, I'm sorry, Bill or someone, could you repeat that just for me? I'm sorry.
So he was asking whether or not the critical access conditions that you referred to apply both in the hospitalist environment, the ED environment, and the clinic environment.
Ah, thank you for that. Yes and no. So sorry, so they absolutely apply to the hospital. So, and you have an emergency department in the hospital. So yes, that would apply. If your physician clinics are under basically the same provider number as the hospital, then yes, it would apply. If not, then so far as I know, no. So basically those regulations around credentialing and privileging are for hospital or for any services that you have that operate under the same provider number. Bill, is that your understanding as well? Did I?
Yes, ma'am. Yes.
Okay, thank you.
Are we under the same provider number?
I don't believe we are.
And the other question I would have, and I'm sorry, I can't be heard, so you can interpret it for me.
There's a mic on.
The other question we have would be in regards to the ED care. If we, under the proposed model that we're using, I would assume that the MD, ED director would be the one who you in charge, but there would still be that avenue to have charts that pertain to the MD to be reviewed by an outside source.
So, again, yes and no. I have seen where critical access hospitals will actively involve their APP staff in peer review activities. So an example, in Taos, we had one of the ED PAs that sat on the peer review committee and often spoke on behalf of the ED perspective. Having the physician there for oversight, if you will, is always a good idea. But I don't know that we always have to have it only done by a physician. And part of it depends on the level of the concern that's being raised.
Right. That's what I thought.
Anything else for Carolyn?
No, just thank you.
Yes, thank you.
You're very welcome. Have a great meeting.
Thanks, Carolyn.
Five-minute recess.
Get your pizza. Hospital.
At 6 o'clock, I'll call the meeting to order. We begin with the pledge allegiance. Pledge
allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Just gonna test the mic real quick and make sure the folks online can you hear us when we're talking to our microphones. Anybody?
Yes, all good. Thank you.
Thank you. All right, we'll call the meeting to order and begin. First order would be to set the agenda. We have one on the table that's been provided.
I would make a motion to set the agenda.
I would second.
Anybody actually second by Taylor to set the agenda? Any discussion? We'll call for the vote. All those in favor? Aye. Any opposed? Motion carried. Second item is public comment. Seeing no public, I'm gonna steal 1 minute of public comment just to inform everyone that, the Industrial Siding Council had their hearing yesterday and today in large. Blue Spruce Operating did receive their permit, so it is full go. Our request is, as well as the Sublette, the entire Sublette request, as well as Lincoln, Sweetwater, and then one more piece from Uinta were received and entered into the record and part of the project. Our ask was $1.12 million. We didn't stand really any cross-examination or didn't really have to defend the request. And at this point, it's a yes from the Industrial Siding Council, but I guess there's a piece where now we are contingent on raising the 1 cent sales tax piece. However that works, the towns have made the request, so it will be, the process is that the towns can request that, and the towns have, and so the commissioners are obligated to put it on the next ballot. The commissioners could also put it on the ballot, but weren't willing to, so it rests in the hands of the towns and those of us that stand to receive impact monies to champion the cause of the 1 cent fee. So there you go. That's all I know.
Thank you.
Moving on, we have committee reports.
We have a consent agenda.
Oh, yeah, that's what the agenda. Approval of consent agenda B, 1B. Sorry, I skipped over that. Family medical leave absence, pharmacy, therapeutics policies, and also meeting minutes on 9/24/25.
I would make a motion to approve the consent agenda.
I will second.
We have a motion and a second to approve the consent agenda. Any discussion? Call for the vote. All those in favor?
Aye.
Any opposed? Motion carried. Next, item 3, committee reports. So we've got the building committee and Tanya's absent, but I do believe Dominic is online with us, then we give the floor to him if he has anything to report.
Hi, good evening, everybody.
He's for health tech.
Mhm.
Can
Not
you
building
hear
committee.
me? Can you hear me okay?
Yes.
Okay, great.
Is
Thank
he
you.
doing the building committee report?
Building.
Dom,
Dom is health tech.
Oh, sorry.
That's okay.
Yeah, sorry, I was a little bit confused myself. Okay, thanks. I'm gonna step.
It looks like
I got a novice here.
Lena is the only one on that might have it. Ask Lena, maybe.
Yeah, I don't see anyone else.
Mm-mm.
Um. Okay, we'll move past the building committee report. Next up, we got Sublette County Health Foundation.
Um, the report's very short for the first time in forever. It's one page, which is great. The checking account's at $800 more or less, and the ICS account is at 1.4 million. There are, according to what we understand, 2 more pay applications coming. So the foundation will have payment on both of those. And after that, we are guessing that it'll be about $500,000 left over for the foundation when the dust settles. Everybody wants to know that number of what's left, but there's just still too many moving parts, so. So we figured that out, and then Bill attended our meeting remotely from San Diego. But it was great, and he, kind of explained to the foundation board the process moving forward for capital construction projects. Where the CEO will approach the foundation and ask for their support in a specific project. And so you all will set the agendas, and then the foundation will be asked to participate and provide support and capital campaign funding. And it'll align with sort of a comprehensive master plan, facility plans, that sort of thing. So Bill laid it out really nicely. The foundation board was grateful to have that clarity. And then the foundation board asked to review their bylaws. So they're sending them to Bill. But now that we finished phase 1, so much of that was flying the airplane and building it. And so now that we have a breath to really look at those foundation bylaws and be sure they're meeting what we want them to do. So that was about it. We're still working on the stained glass for the sanctuary. We did approve a bid from G Landscaping to do the employee break area. And then when the skilled residents moved, we did welcome baskets for them, which was great. So everybody got a little basket with fuzzy worm socks, grippy socks, and crossword puzzles and snacks and a little mug. And they were just tickled pink with the quality of the rooms and the gorgeousness in the bathrooms and just a little cherry on top. So the Callie's Helping Hands dinner is all the nonprofits for Foundation 23. So we'll all be there. It's Wednesday, November 12th at 6. So it's on your nonprofit or the foundation report. Everyone's welcome to attend, and then all the nonprofits will get their checks, and they haven't told us how much we raised yet. And then I would say we're in a bit of a pause. A lot of the pledges for this campaign were 3-year pledges, and they're finishing in 2025. So as we move forward to really come into 2026 with a project, whether it's assisted living or employee dormitories or full-on surgery suite or, whatever direction we go, we're just making sure we kind of get that out of the gates. The foundation's ready to move and start raising more money. Any questions for the foundation? Thank you. Appreciate it.
All right, on section 4 of our agenda with leadership reports. First up is operations report. Yvonne.
Thank you. We have your reports attached in diligent. I just wanted to highlight a couple items. We had the Heritage Home residents move up last week, and it's been very exciting. The atmosphere has changed. It's busy, and it's great to see all the staff. And I had forgotten how to park my truck, but now I remember because there's a whole bunch of parking taken up now because we're all together. So it's wonderful. With that, we opened up the cafe this past Monday. It's been a hit, and please come up. We want the whole community to come up. And even if you don't have a loved one to visit at the hospital or at Heritage Home, we still need you to try our $1 cinnamon rolls. We have, with EMS, we've got a very exciting community integrated health, again, care coordination program, which was a success under nursing. It was run by one person and it was getting pretty heavy. And so we thought it best to move that program into EMS, and we've got 4 people who are already working on shift. We've got one person per shift that can attend to our community needs. And this is also going to start tying in to TCM, which is Transitional Care Management. So Lane and I participated in a meeting. Lane's been a great resource for us. And so what TCM is doing is and I'll let you go into it because you're a lot smarter than me, Lane, with this. But so that's where when someone is discharged from the hospital or in a few other variable situations, they are able for us to go to them and to make sure that they're okay. What can we do for you? And that cuts down on readmissions and also is just best for the community. And that's just us serving the community as best we can. And so we're very excited about that. BJ and myself, Lane and Aaron Macias is a paramedic with us. He's been a great resource and asset. And he hails from Cody and he's moving here to Sublette County. But we're gonna meet with Bill and kind of get all the fine tuning out. And I want to just give a shout out to Luann Height, who, the community member who has been such a great ambassador for the community and helping us bridge that gap. So appreciate that. We're also preparing for critical access hospital designation. That takes a little bit more finessing with the policies and protocols, but we've got a good, we're ahead of the game on that and hope that the furlough doesn't affect us at all with that. We have the SLIP board that I'll be attending November 7th in Cheyenne, and we'll be finalizing hopefully the TEA grant for Tahoe. So we're very appreciative to the state for that. And then I just want to point out one more thing. Our addiction clinic is going fantastic. Again, that's run by Noah, and Penny Jensen is our navigator with that, and substance use navigator. So she does the booking. She keeps in contact with everyone. And we were doing it once a month and it's already fully booked. And so we're already talking to Noah about increasing that. So we've got a full day booked. And then we've been in contact with the schools so that we can get these kids off of the vapes. And so we're going to do some education with them as well. So do you have any questions for the operations report?
No, thank you.
I would just note though that we don't have that in diligence.
Yeah, we didn't have the operations.
Oh, it's okay.
You did a great job.
Yes. Jameson, before you move on, Lena had an update. She couldn't hear you
Yeah, go ahead.
on the building aspect of it. Lena?
Go ahead, Lena.
Oh, sorry, Jameson, your voice is very low, so I kind of miss it sometimes via Zoom.
Mine's not too great tonight.
Hey, so you're wanting to know about the building report. Things are coming along really well. We're kind of closing things up, and wrapping things up. We've got a couple of things that are hanging out there, but we're waiting on either materials or parts. We've had a couple of snags just with things like not functioning like we thought they would or what have you, but they're working on fixes with those right now. I believe the construction crew did a really good job in getting the long-term care facility ready for the residents to move in. We are waiting on flooring because we had some flooring damage due to furniture moving and so forth. So as soon as that comes in, we can address fixing that. But other than that, everything's going along really well. We've had kind of some little weird things happen, like a glass in the ER. One of the sliding doors shattered out of nowhere, but that will be replaced if it hasn't already been. But yeah, things are looking really well. The only kind of downside right now to the construction project is the government shutdown, right? So we're sitting here waiting for the USDA to be able to come back on so that they can process our September pay up, as well as numerous change orders. So that's kind of 10,000 foot view.
Question?
Mm.
Okay, thank you, Lena.
You bet.
Next up, provider report with Dr. Burnett.
Well, good evening. All is well on the provider front. Have no issues or concerns. We have had some very good progress and conversations with Bill with regards to our staffing model and change. It's been well received by the providers. And I won't go into that anymore because I'm sure Bill will contain that or have that in his report. We're making good progress there and very optimistic about that.
Any
Thank
questions?
Thank you.
And conditioning goes on.
Thank you. Pass on our thanks to the crew that's doing a lot.
Okay.
Next up, skilled nursing. I think Dawn, I thought I saw mine.
Yes, she is.
Yep, I'm on. Thank you guys for letting me attend via the internet. And you do not have a report from me because I'm focusing on the best news, which is we are finally up here after so many delays. I'm actually reporting from the skilled nursing side. Like Lena mentioned, we're overcoming some things, but I want to really focus on how amazing the team did. And I want to give a couple of people some extra credit. I allotted 7 hours and 45 minutes for the move in terms of our emergency preparedness plan. We've talked a lot about, we were doing a move of residents, but we were also treating it as a potential, mock emergency and how well our emergency response hit our goals. And so we allotted 7 hours and 45 minutes and were completed in 4 hours and 10 minutes. So that is because the team communicated well, transportation went well. And on that end, I really want to thank BJ and his team. We did have a couple of residents who had not done well coming off of COVID. You guys knew we were in the COVID outbreak right before we moved. And they dedicated a bus to us and moved up some of our residents via EMS, which made for a much smoother transition and resident experience. So I really wanted to thank him for allotting those resources. I know they're not easy to come by. So we're up here and all of the private rooms are full. Your current census today is 38. We moved up with 39 and have had one person discharge. We do have 5 people on a waiting list. There were some people, in case you get approached in the community, who wanted to move right after we came up here. They were waiting for the new building, and we love that. We want to make sure that we have our process kinks worked out before we do a lot of admissions. So we do have 5 that will be pending and should be with us shortly. So it's been a really wonderful experience. Sharetta has also done such a good job of helping our apartment residents get their meals. So right now she's working on that, and we are doing some combined activities. For instance, Halloween. We are going to be taking residents who wish to go from the nursing home up on the hill down to the apartments, because that's the cornerstone of the pathway that's set out by the business trick or treat. So you will still see us quite active down there. And I could not be more pleased. These private rooms, this space is beautiful. So if you have an opportunity, please come visit us. I'd be happy to walk you around. I think you will be very proud of the product that this organization has produced. And that is all I have for today. Any questions?
Oh, very good. Thank you, Dawn.
Hey, thank you.
I would just say that's amazing that you planned 7 hours, 45 minutes and finished it in 4. That's awesome.
Oh, it was great. The zones worked well. We had no resident or family complaints, and BJ also served as a, I guess, critic, for lack of a better word, overseeing how the process worked. And he had a couple of really good suggestions that should we ever have to do this, we'll implement, but I could not be more pleased. So thank you.
We'll pass on our gratitude to everyone on your staff.
Yes.
We will. Thanks a lot.
Next up, health check with Dominic Sines.
Good evening, everybody, again. I hope you enjoy my building report. First thing I just wanted to mention is just a few staffing changes from our side. I wanted to let you know that Patrick, who was has been the assigned VP of Finance on the Sublette hospital account, is going to be leaving at the end of next week. He's actually taking a position as a CFO for Coos Bay in Oregon. We do already have a replacement for Patrick. His name is John Freeman. He is starting on Monday. So in the very, very near future, I'll be introducing you to John Freeman, but most certainly we'll be connecting Bill and John Freeman early next week. Bill, just a question. Have you worked with John Freeman before?
Yes, I did.
Okay, good. Excellent. Another new position that has started, we have Mark Armstrong, who's joined as the president of hospital operations. He'll be reporting into myself as well as our CEO, Derek Morkel. We'll also be introducing him in the very near future to you guys. Just got to establish when is the most appropriate time to do so. Obviously, with John Freeman as regional VP, he will be reporting to me on the Sublette hospital account as well. I hope you found Carolyn's session worthwhile and educational, and I thought it was something that was pretty good in terms of, you know, where you guys are sitting right now in terms of the stages of the hospital. Very, very pleased to see that she was happy with your new format for credentialing. So obviously you've got a nice green light on that one. I had discussed with Tanya going back probably about a month ago, if not more, and I think I mentioned it to the board as well in the last board meeting, that my aim is to try and introduce one of our consultants to the board at every monthly board meeting, if at all possible. Tanya and Bill really liked that idea. So for the next board meeting, I'd like to bring in, with the board's approval, I'd like to bring in another one of our consultants to come in and present. And, you know, we've got so many areas which we'd like to cover with the board. We'd like to cover GPO, we'd like to cover strategic planning, and the list goes on. I thought that the best person for the next meeting would probably be our strategic planning director. Her name is Julie Haynes, because I think that it's sort of due time, or certainly just around the corner, when we should start working on the hospital strategic plan. So I would love for her to come in at the next meeting if possible and take you through the strategic planning process and how we go about that, which then leads us up to putting together our management action plan for the hospital. But I'll obviously, you know, take that offline and discuss it with Tanya and with Bill, but I think she would be probably the best person for the next meeting. What I've been...
Don, let's take a poll really quick. Is everybody green light on
Yeah.
on that for the next meeting?
I am.
You do with that, no? Yes. Perfect. Hey, we're green light on that, Don.
Okay, excellent.
We love the strategic plan.
Love it. Thank you. What I've been concentrating on pretty heavily over the last few weeks, or certainly a month, is I've been helping our hospitals quite a lot with their rural transformation fund applications. So, you know, each of the states has obviously a different way of going about submitting their applications, and as you know, the application is submitted by the state. But I started off about 4 or 5 weeks ago, really diving in with CMS to uncover and work out the actual application process, as well as the details and the intrinsics of the application itself. And it was quite a head scratcher initially, because initially, you know, the information that we got from CMS was that the application process was going to be fairly simple. And once I got into actually going through the application in detail, I found out that, as most people did, that it was actually a very, very complex application process and pretty detailed. So I'm happy that I was able to help and in some way add value to the Wyoming Hospital Association and the Wyoming State with their application. Together with Billings Clinic, we put together a template for the hospitals. The hospitals were able to use the template, and we used that template to gather information which we could then send through to the state. So the deadline for that, as many of you will know, and those of you who don't know, the deadline is the 5th of November. And I know that Bill is going to cover this a little bit in his update, but I know that the application is going to be shared with Bill, I think, early next week for his review. The other thing that I've been working on a great deal on is actually engaging our consultants with different parts of the hospital, as well as with Bill. So getting Jeff on our GPO team, getting Margaret on RevCycle, swing bed, all the other aspects. I've really been working to get these regular meetings set up, and they are now, there are a few still outstanding, but they're now starting to happen on a regular basis. Alreen is meeting with the Ocean team every week. Margaret is meeting with the RevCycle team every single week. And the meeting with Jeff Hollingsworth for GPO will kick off next week. We had a little bit of a delay there between Jeff being away as well as Bill being away at that time. So that's coming along really nicely. The other thing that I wanted to mention today was just a quick conversation with regards to RevCycle. As we know, there's a lot going on in RevCycle, and there's a lot more that needs to go on in RevCycle because it's an area of the hospital that is particularly weak from my perspective. And there's a number of different reasons for that. But I did communicate with Tanya just before she went away that because of the difficulties that we've been having from a positional point of view and a staffing point of view, I did communicate to her that I offered to take on the billing for the hospital in the interim. So whether it's a month, 2 months, or 3 months, Health Tech will take on the billing just to help the hospital through this stage. And we're going to do that pro bono. We're not going to charge for it. We have some people on deck coming up at the end of this month. So in fact, by the beginning of next week, we will have a couple of FTEs that we can use on the Sublette RevCycle billing. And we're going to do that for gratis. We're not going to be charging you guys for that, just to help you out in the interim. And then the last thing that I have is I know that there's a meeting. I'm just waiting for that confirmation, and I think that it is tentatively or pencil booked for the 5th, which is next week, the 5th of November, which is a meeting between myself, a special meeting with myself and the board. I'm still waiting for that confirmation, but I have blocked off the time to spend that time to talk to the board. And that's about all I have. The other areas, I connected with Bill this morning. I connected with him on Monday. We talk a lot. We get on the phone a lot. A lot of the other specific areas Bill is going to be covering in his CEO update. So that's all I have for this evening, everyone.
Thank you. Any questions?
No, lots of good information. Thank you.
Next up, CNO, Lane Harrington.
Okay, thank you. I do have a PowerPoint, and Jan will pull it up and you'll be able to see it and everybody else can share it. Okay, so just a quick CNO update. I wanted to make sure that you were aware that I'm going to be using a pillars framework reporting structure.
Excellent.
Next slide.
Just a second.
Okay.
I need to share it, actually.
Okay.
There we go.
See. So in the pillars framework reporting structure, we talk about people, quality, growth, service, and finance. And under people, you should expect things of report like what are we doing for education? What are we doing about staffing? What's going on with employee events? How are we doing with employee engagement? And what does that look like on a cultural basis and overall morale? We also cover special recognition like the Daisy Award, stuff like that. So I'll be sharing with you as those events come along. Under quality, we'll be looking at matrix and data. We're talking about the CMS required reporting, and then things like NHSN and CDC. So I'll go into a little bit more depth at a later time with that. With growth, we'll talk about special interests like data trending and volumes, and any new service lines that will be coming on board, how they're doing. I'll look back, what were we last month? How are we doing this month? Is the trend going in the right direction, and are we growing? And then for services, that's mainly about the patient experience and HCAHPS. And HCAHPS talks about the patient's perception of their care. And we will work through Press Ganey will be our vendor that provides that patient experience survey. And then finance is finance, and it's all around and affects us every day. So next slide. So as y'all know, when we had our survey during our PPS accreditation survey, one of our CIHQ findings cited was an ED standard that was new on July 1st of 2025, which requires the emergency department to be able to manage OB emergencies, complications, and post-delivery care. Specifically, this relates to postpartum hemorrhage. So what we have done, next slide, please, is on October the 13th, we held our first PPH drill. So you can see all of the attendance. We had at least 20 participants there. Of course, EMS was there, our providers were there, and Perry did a great job of leading us through this. You can see we had dummy come in. You know, of course, she had the postpartum hemorrhage, there was blood everywhere. And so, next slide. You can see that our drill actually included policy review, our health stream education assignment and update. We have to be able to provide a blood transfusion process. So we have done education with all of the nursing staff for that. We had to have an OB cart with location in one of the trauma bays where it was readily available with all the cards on top that walks us through what happens. It won't happen very often. We hope that it never happens, but odds are that it will happen at some point. And we just wanted to make sure that we checked all the boxes and all of the requirements. We have to have of course, the designated emergency card. You have to do drills annually. This is a requirement. You have to document it and show the debrief after the fact. So we have done all of that. Next one. And that's just more pictures of Raleigh doing her thing. And I'm telling you, the physicians got into it. The nurses were loving it. Everybody was communicating well. We had the EMS, of course, pharmacy, because pharmacy has a huge part of this. Part of the drill was, okay, so Lindsay, you're the nurse taking care of the patient. I need for you to go to the Pyxis and pull out the PPH kit. So she would go to the med room, put in the code, pull it out, and then Susie, our pharmacist, was there to make sure that they knew where everything was and how it should be pulled, how it should be measured, how it should be pulled up, and then how it should be given. So we had lab who covered the blood products with us, and then of course nursing and the providers. It was a fun event, and we're doing it again tomorrow night if you want to stop by for a preview. Because not everybody made it to those 2 sessions. Okay, next we talk about people, but it kind of rolls into finance because when we talk about staffing, one of the highest costs, of course, is not only nursing, but it's your salary dollars for the hospital performance. So we have 2 new RNs that just started actually yesterday. So we're very excited that they're coming on full time. They're local residents. One came from Jackson, and the other one has just recently moved here with her husband. So we have 2 CNAs starting in early November. And I want to talk to you a little bit about what we do for our ED registration process. So if you come in through those doors that go into where I guess we call it the welcome center. I call it triage or ED registration. We've had 2 people there, one clinician, a CNA or an MA, someone that is clinically and then we had one patient access, was a registration person. We don't need 2 people there. One person with the right training can do that. So we're looking at that 24/7. So what we're doing is we're taking two 24/7s and taking it down to one 24/7. So in essence, redeploying those people, or if they are travelers, like we have used some of the travel CNAs in there as our CNA person, that's a lot of money right there. And you'll see that actually on the next slide. So by combining those two positions into one role, is a cost savings of about 175,000 annually. And that will be effective at the beginning of the pay period, December 7th. So we're on a fast track to get the job descriptions done, which they have been written. The positions are now posted. And just today, I actually got a salary guide for that. So we're very excited to have that position ready. So on finance, you can see that RN traveler, and we've had 6 of them when I first got there. They come in for 13 weeks, pay the agency $90 an hour. So $252,000, you can see that for the RNs, and $113,000 for CNAs. We pay our CNAs around 20 or so dollars an hour. They're making 52. We pay our nurses high end around 45, so twice what we're paying. So very much needed at the time to get us over the hump. But we've been really fortunate in filling those positions and getting people onboarded. So my plan is the traveler reduction. We've already canceled 2 early for a savings of about 38,000. We have already pushed from 4 CNAs to 3 effective in September for cost savings there. We're going to end 2 RN contracts early. They're not due to expire, I don't think, until the beginning of December. So we can pick up a couple of weeks there with the 2 new hires that we just had start today. And then we'll end the other 2 CNA contracts for another cost savings. So the total reduction in the agency cost is about 72,000. And when you look at this is really fast track because this is only a 3-month period trying to get that out. So total financial productivity transitions, you can see there is almost $250,000. So we're in 3 months.
Wow.
So we're, well, over the year, of course, for 4 FTEs, but reducing travelers. Okay, growth. So I know you can't really see the numbers there. I can hardly see them on my screen. And I promise next time they will be bigger. But I can tell you that on the left-hand side of the screen, you'll see the growth for the hospital. In August, patient days, we had 45 inpatient patient days. For our length of stay was 3.2 days. And then our total admissions in August for inpatients was 14. So then if you move over to September, you can see we had 92 patient days. Our length of stay bumped up to 4. We had 1 or 2 patients that stayed longer than they probably needed to. But we did increase admissions, which is really what we're going to look at is admissions and discharges, right? We had 21 admissions on the inpatient side. For the ED, total visits for August, we had 285. In September, it dropped a little, 272, but not bad. Still a good number. For total transfers in August, we transferred 41 patients out. And for September, we transferred out 46 patients. Our conversion to inpatient from the emergency department, in August, we had 13, and in September, we had 21. So most of these numbers move in the right direction. We just need to increase our volume. Is a big thing. Slide. So there's a lot in quality and service. So this is just a snapshot so that we can plan for next time. I might talk about people in finance. I might just talk about quality and service. And just to recap that, so the HAIs or hospital-acquired infections, we'll look at, did we have any MRSA? Did we have any CLEBC? That's central line associated bloodstream infections. I will teach you that. I'll give you those acronyms and what that means. When I say a CAUTI, you'll know, oh, that's a catheter associated UTI, urinary tract infection. You will become very proficient clinician for the acronyms. So more to come on that. We'll talk about hospital acquired conditions, different from infections. These are conditions. These are things like pressure ulcers, falls with injury, medication errors, those types of things. And then we'll talk some about NHSN, which is the National Healthcare Safety Network. It's a CDC reporting database where hospitals report all of their information and then they get graded and information sent back. And so that's important because we want to be compared to our size hospital. Okay, so when we start reporting that, hopefully we won't have anything to report, but if we do, then that's where it goes. To be spun around and said, okay, you're doing better than average, doing worse than average, or you're average in your care. And then STEM events, which I hope we never have to talk about here. Those are things that should never happen. Those are unplanned deaths. Those are unplanned injuries without recovery, serious injuries, those types of things that happen within the hospital confines. And then in service, the HCAHPS, which is really the patient's perception of their care. So that's where Press Gaming, our vendor, will reach out with a survey, either by phone or by paper. And then all of those results go straight to them. They tabulate it all, and then they tell us how we're doing with the patient experience. They will ask questions like, did your physician listen to you? Did they explain things in a way that you can understand? Did they talk to you about your medications? Did they help you plan for your next period of your healthcare services? Were the nurses treat you with courtesy and respect? Did they listen carefully? All of those types of questions that are really drive perception. In other words, did we take really good care of you? And were you happy with your care? Not were we clinically competent and sound, but what was your perception of how we cared for you? So it's very important. So we started what we call patient rounding. We go in the patient's room. How has your care been? You know, did your nurses come in? Did they include you in the handover report? Did they update your whiteboard to make sure that our staff are doing what they should be doing for our patients? Okay. In a nutshell, that was a lot, but more to come. Are there any questions for me?
Are those Press Gaming surveys already going out for hospital and emergency?
They have not been, the questions have not all been vetted and selected.
Okay,
for
so
the
those are
hospital side.
going out.
So they are not going out yet.
Are they still going out on the clinical side?
I
I don't think so.
No, because we
They stopped it.
paused it all,
It's
and then to reassess this, then it'll open up.
Feedback, format. I don't like. I think it was.
No, I loved it.
Okay.
Love the report.
Yes.
Thank you. Thank you for putting it together.
Section F, and was our finance report. And we've got Bill Patton probably leading and Kendra supporting.
So I'll do the play-by-play, she'll do the cover. So for September, and then for the first few months of the year, that's what I'm going to be talking about. So the first thing I want to say is mill levy income, that first line, that shouldn't be in that category. So we talked about this at Finance Committee. We're actually going to move that. It either needs to be down in the, what this calls cost of sales. That should be adjustments to income, or on the second page, other income. What this first section should be is the income related to services that we provide, patient care services. So as an example, when we start recognizing the meals from the cafe, that shouldn't be in this section of the report because that's not related to patient care. So we're going to take that 250,000 normally and move it into a different category. So if you look, and I'm going to compare budget against the actuals. So if you look at the total income line for the month of September, 3.6 million. We had budgeted just shy of 4.5 million. So we had a negative variance of $838,000 for the month. For the year so far, we've got just under 9 million in income. We had budgeted 13.4, so we're negative 4.4 million already. And then you do the adjustments, and the one that I really look at is that first one, the insurance adjustments. So you can see we budgeted 866,000, but we actually had 1.2 million. Part of the reason that number is so much higher is because Medicare and Medicaid are reflected in that right now. So once we start billing them, then those numbers will be reversed. So right now, since they're not billable, they're looked at as a write-off. Once we're able to bill them, they'll be brought back on. But still, that means a negative if you look at all of the adjustments, what they call total cost of sales, 1.37 million against a budget of only $1 million. So we were negative 362,000. So when you add those together for the month, we were negative on the income 1.2 million. Not the way that you want to be. And then for the year, 5.7, almost 5.8 million is what we actually got. What we budgeted was 10.3, 10.4 million. So negative variance of 4.6 million. So volumes are really an issue for us. That's what this first part is all about. How much volume, how much care are we providing? On the expense side, the first three lines, wages, payroll, and benefits, all are trending real good against budget, both for the month and for the year. So even though we're scrutinizing salaries as it relates to budget, that's pretty good. If you go to the next page, the other big number that relates to people is line item 7,000 contract labor. And so we had 675,000 in expense against a budget of 643. That's actually really close for a number that big. And in year to date, we're 1.7 million in actual expense against a budget of 1.9. So we're positive a little over 200,000 there. So the work that Elaine talked about in trying to reduce our reliance on travelers, so that's going to show up even more positively in that specific line. So then I come down to total expenses, just over $3 million for the month. Budget was 3.1 million. So we were positive on expenses by $100,000. Not a lot, but for still being in what I would call a startup phase, that's pretty good. And then for year to date, 8.7 million total expenses against a budget of 9.4 million. So again, we're positive, $660,000. So on the, and then you have the other non-operational income. And so it nets out, instead of the loss of 759, it ends up being 584 loss against a profit that was budgeted at 338. So that's $900,000 negative swing. And then year to date, 2.4 million was the actual loss. Budget was $1 million profit. So a negative swing of 3.4 million. So as I look at these numbers, the expenses, even though we're going to focus a lot on them, the expenses are pretty much in line with what the budget predicted. It's the revenues, it's our volumes. So like today, if I remember right, we had no inpatients, or did we have one? We had one. Our average, I think, is 2.4, 2.5, something like that. In the ER, our average is somewhere around 7 a day. So in my report that I'll get to in just a minute, there are some specific things I think we need to work on as it relates to volumes. But from the financial perspective, the expense side of it made me feel pretty good. It's the revenue side that I have a lot of worries about. So I'm happy to answer any questions you have on the financials.
How much of the revenue or lack of revenue due to just not being able to bill currently like we, because we're not caught up for that yet, right? And then
So yeah, we're in what's called an accrual system.
Okay.
So
So that is-
when we bill it, isn't reflected here. This is reflected when we charged for it.
okay,
And when we
When the
bill it
service
is a
is-
different thing. So that would be balance sheet. So that would be your accounts receivable and that sort of thing. So a business might do cash accrual. So then that would be, I'm looking at actually how many times I'm opening the cash drawer. Hospitals don't do their accounting that way. They do it on accrual when something actually was booked.
Okay.
But to your point, the number that I use to estimate the impact of not being able to bill would be that 3120 and the cost of sales, the insurance adjustments. So 1.2 million against a budget of 890 million. So 345,000. That's the number that I would approximate that we're not being able to bill for the 1 month. That includes other adjustments, but those, as I understand it, are included in that line. You're percolating. There's another question.
I am percolating, yeah. I guess I'm not sure yet, so.
Okay. Other questions?
Not yet.
And for tonight, I wasn't going to go through the breakdown by the different business lines
Okay.
because there are some, the way that we're recognizing the numbers. For example, the mill levy money is all being booked to the Pinedale Clinic. I guess that's the way it always was done before. But so we need to look at how we're doing that now. So until we really decide that we're booking the numbers properly, I don't think it's worth your time.
That's
The
fair.
big picture is what I think you need to focus on for right now.
So in that, like, are we just not having as many admissions as we budgeted for? And then obviously like, you know, how it will work after with critical access, not gonna make a big difference for this period, but.
Right, so I don't know what assumptions, volume assumptions were made. It's my sense that it probably was driven by the pro forma that I big did.
Yes.
At least that's the way that I would have done it, is I would have looked back at what were the numbers estimated, and then I would use those. And then if I had a reason to tweak any of them, but I would only tweak them if I had a specific reason. The other thing that I'll get ahead of myself in my board report, I talk about one of the things I think we need to do is we need to get people to understand that they don't have to go to Jackson anymore. That we need to change the pattern of voting with their feet. That's what I call it. And so I think we need to do some very specific targeted marketing. Even though everyone knows we're here, do they really think about us when they actually have to see a doctor? And then the other part that I'll talk about is we need to make sure that we have capacity. So if a patient comes into the ER, doesn't currently have a doctor, we need to have capacity so that we can refer them to one of our doctors. So there are things that I think we can do to address the volume side. I was talking with Carrie earlier last night, the restaurant where I had supper. The owner came over. I always wear my name tag when I'm out in public. I want people to ask me, are you from the hospital? Because then I get to talk about the hospital. And so he did. And we talked about needing to get people to change their patterns. And he said that he had opened up a new restaurant and it took a while before people would start going to it. But after a while, it got to be busy. He said, you just need to be patient. I didn't say I'm not a very patient person, but I think it is to be expected that there will be this transition period where we need to get people used to coming to us rather than going to Jackson or somewhere else. So if there's nothing else on the finance, then I've just shift gears and started to
See you.
my other report. Yeah.
Sorry, Bill, I do have one thing if you don't mind.
Go ahead.
I think that I don't know when the budget was presented and signed off. I don't have those specifics. I think that the original pro forma that the budget is based on from Eid Bailey was too much of a stretch. And I think that's the situation we're in because it is too much of a stretch. I think that what we should think about doing in the very, very near future is I think we should think about doing a rebudget of that budget, because I don't think it is realistic. Just a thought. And I can get, John Freeman on Monday, when he starts on Monday, and even Mark, they can give us a hand. And if you and the board are happy with that, then I can assign somebody to actually look at a more realistic budget.
So I would agree with the assessment that the budget was optimistic, because I've gone back and read the pro forma. I thought it was optimistic. So when you do a pro forma like that, you're supposed to do a plus 10% and a minus 10%. So if your volumes go up by 10% above what you anticipated, what does that do? And if your volumes are 10% less than you budgeted, what does that do? And that analysis was done, but I agree. When I read the report, I thought, based on the track record as I understood it from the clinics and EMS, that it was optimistic. That's a nice way to say it. So I think the idea of going back and revisiting the budget and making sure that it is a realistic reflection of what our operation should be would be a good exercise.
And I believe that budget was reviewed and approved at our June in-person meeting, if I recall correctly.
So it still would be
Yeah.
what I'll call theoretical.
Right.
So
Just to
we've
give
got-
context where that is
Yeah.
on what meeting.
And so we have now, it's not a long track record, but we have a few months of actual.
Yeah.
That we could then do probably a more realistic budget. So with the generous offer that the Damas made, unless the board says differently, I'm going to assume the light is green. And
Yes.
we're going to work to put together another budget. And
Yeah.
whether we can have that done, I guess I'd like to see us have it done no later than the end of the year, so that we would have a new 6-month budget for the last half of the fiscal year.
I like that idea.
And I think once, as soon as we start getting this Ocean data feed, that's going to make a massive difference to our lives in terms of having accuracy and real-time data as well. So that's coming soon. Elreen's told me that data feed should be coming through to us in the next 3 weeks, and it should be happening. So that's going to make a massive difference to our accuracy as well as forecasting.
Thanks, Tom. So moving into my CEO report, just wanted to let you know that we're still working on the on-call and the callback policies. We've had good discussions about that, but it has been a little bit more complicated than I think I originally anticipated. So what we're wanting to do is to make sure that we have all the departments that need to be on call, and then that we're paying people fairly and appropriately based on the policy. So that's what we're working on. And some of the callback may well replace some of the supplemental pay policies that we have in place now. So when an employee calls off and we need to fill a shift with just a few hours notice, we have this bonus program in place to incent people to sign up. Well, sometimes that program is more generous than time and a half. And in my experience, you rarely want to go more than time and a half. And so we may be able to accomplish the incentive using the call-in policy, which automatically kicks people into time and a half. So we're going to see whether we can streamline some of those processes, but still have an appropriate incentive when we need to fill a shift. This one, I'm assuming the light is red unless you tell me differently. So I've been told that we typically have provided holiday gifts to our employees, something in the range of $40 per employee. Given our financial situation, though, as I said, I'm assuming the light is red unless you tell me otherwise. I'd be happy for you to tell me otherwise, but I'm assuming it's red. Senior leadership has spent a lot of time talking about putting non-medical staff, CME, and education-related expenses on hold. And so we already have developed the memo to staff, but I wanted to inform the board of this before we actually send it out. So this is another one I'm assuming is green, unless you tell me differently. we're gonna put all medical staff have a contractual right to CME dollars because they have to get CME, for their license. There will be a few exceptions, and so we are granting the opportunity for people to say, hey, I have a special case. So it's not a hard and fast no, but in general, we're going to put education and expenses on hold for probably 2 or 3 months. Staffing issues. So while I don't think we can fix our current financial problems with staffing cuts, I do believe that there are some adjustments in staffing costs that need to be done, and I'll be talking in more detail during the executive session about that. I have a couple of questions about CEO recruitment. So there is a in-state Wyoming Health Resources Network recruiting company. They work on contingency. It's a $25,000 contingency fee. They say that they have several folks within the state that are interested in our CEO position. Of course, they want us to sign the contract before they will give us those names. We don't have to pay unless we hire somebody. So there's no risk in doing this, but I don't want to sign the contract without a thumbs up from the board. I think it's a good idea to sign. As I say, no risk unless you hire somebody, and $25,000 isn't a bad fee for a CEO. So I'm going to assume the light is green unless you tell me differently. If you don't want me to sign it, that's fine. I think there's no risk in signing. The other thing, I need to know how you want me to handle when people call. So I've had one CEO from in the state call me and say, hey, I'd like to have my name put in for your CEO position. Do you want me to forward that to Tanya? Do you want me to forward that to Dom? Do you want me to forward that to Dom and Tanya? Do you want me to forward it to HR? How do you want me to handle those sorts of inquiries?
I think we're gonna have a discussion in executive session.
And then there are a couple of positions that I'm going to suggest we need to add that we'll talk about in executive session. One that we're going to get to add without any cost to us because we're already paying for it. Apogee currently has a support person for the physicians. It's a full-time position. Given our volumes, that person has a lot of free time on their hands. So I approached Apogee and said, can we assign duties to this person? So we decided just today at senior leadership, we're going to make this person a half-time admin assistant to support COO, CNO, and Dom. And then they can assign, so like Lane wants to do patient phone calls. Well, that would be a perfect thing for this person to do. So we're going to take advantage of this free half of an FTE by creating a new admin assistant position. One thing, not for tonight, but at a future meeting, I want to discuss leadership titles with you. I think we need to have standardized definitions of what a title means. So when we say a director, what is it? Yeah, versus a manager. What does that mean? And so I'll provide you with sort of a framework for the conversation, but I'm going to have senior leadership go through this first, and then we're going to bring it to the board for conversation so that we can all be on the same page as far as our titles. Because my sense is, and I think it was Lindsay I was talking to, we like to give titles to people. The problem is titles usually involve money. And so I want to make sure that we're doing it appropriately. So that's something you can look forward to. We'll be working on in the future. We've begun reviewing CVs related to the 2 new urgent care positions with the new ED staffing model that we're moving forward with. And as Dr. Burnett mentioned, medical staff is very pleased with this new model. But we already have CVs, and so we're beginning the process of hiring those. We want to have them in place by the 4th of January. And then quite a few of the ARC doctors want to be our doctor. And so there are 3 of them that have worked enough hours that we're not going to have to pay a recruitment fee to ARC if we were to hire them. There are several others that have put their name in the hat, but they don't have enough hours. And as I said at senior leadership, I'm not going to pay a recruitment fee if I don't have to. And so we're actually getting input from staff, so from the physicians, from the nurses, from lab and x-ray. Since they've already worked with these doctors, why not get their opinion? So my goal is to have that survey done by the end of next week so that then I can enter into contract negotiations. I've already sat down with 2 of the doctors. So very pleased with how that's going. So in going to the finance section of my comments, I already mentioned that I think that our unprofitability is largely driven from a volume perspective, although we are going to be looking at expenses until volumes grow. But I'll tell you that I don't think that we can cut our way to break even. I don't think we have enough people. We can make a dent, but I don't think there should be an expectation of that. And then this is the part I said I was going to, we need to get the community to vote with their feet and bring their care to us. So we need that capacity in the clinics. We already have plenty of capacity in the ED, in the inpatient and the outpatient areas. And then I really think we need to sit down and we need to think about some very targeted marketing so that we can bring it home to people that they can keep their care local. Clinic structure. So I think you know that there's been a question about should we convert our clinics to a rural health clinic? There are at least 2 other models that I think need to be considered. So they're under a critical access designation. You can have what are called provider-based clinics. And then the third one is a federally qualified health center. So there are at least 3 different models. They're organizational models, they're payment models. Each of them has different benefits associated with them. I think that we need to do an actual financial analysis to see which model is most beneficial to us. It's going to be a lot of work to convert our clinics into whatever we want to convert them to. I don't want to get it wrong. So I've talked with Ag Bailey already and gotten an estimate. So they're estimating that it will cost $25,000 to $30,000 to do this work. And while it's not money that I want to spend, I think it's money we need to spend in order to make the right decision. So just to tell you a little bit about the Federally Qualified Health Center and the reason why I think it needs to be considered. So FQHCs carry with them enhanced reimbursement over normal fee schedule. They have a unique governance requirement that 51% of the ward has to be receiving care from that clinic. So if you guys aren't getting your care locally, then that's going to be an issue in the FQHC model. It also brings with it what's called Federal Tort Claims Act protections. So the insurance that you have is less in a FQHC model than it would be in an RHC model. But the reason that I really want to look at FQHC is that another clinic could put a clinic here. So you have what you would call your home clinic, and then you have satellite locations that you can put in. And so in other states, I've seen this where New Mexico, for example, there was a clinic in Albuquerque that decided Gallup would be a good location for them to have a satellite. And so it's a very easy process for them to extend, and then they can come in and they can compete with critical access hospitals. So it's not uncommon for them to have a lab, for them to have some sort of imaging presence. And so as I think about this, this is a protectionist strategy on my part. Should we do our own FQHC that would then block anyone else from coming in? And I want to make sure that financially there would be justification to do that. So that's why I think we need to spend the money to have the analysis done. And I would like to have it done in the next couple of months so that first of the year we can hit the ground running on converting our clinics to whatever status it needs to be. So about the time that we would start to get benefit from critical access, we could begin working to get more benefit out of our clinics. Does that make sense?
Mhm.
Okay, so as I said, I'm assuming the light is green unless you tell me otherwise. I don't want to spend the money, but I think we need to. Portable ultrasound, we had talked about this at the last meeting. The clinic actually ended up picking a smaller and much less expensive unit than I was expecting. So I was thinking that an ultrasound would probably be in the 30 to 40,000 range. They picked one less than $5,000. So I said, make it happen. GPO conversion. So Don touched on that, and I got a note from Jack Hollingsworth. He's the GPO guru from Health Tech. He says we're continuing the med-surg vendor discussions and contract enrollments and in the early stages of reviewing lab and dietary data and preferred alignments with the department directors. Everyone at the hospital has been responsive and great to work with. There's huge opportunity here with the GPO conversion. And so I'll have one more comment to make about that in the executive session. This is another one I'm assuming is green, unless you tell me otherwise. There's a program called the National Health Service Corps. So the National Health Service Corps is a program for providers to sign up, and then they're considered scholars, National Health Service Corps scholars. But what it means is they get loan repayment money. And it's anywhere from a 2-year to a 5-year contract. And it's usually at least $25,000 a year that they get. $20,000 for loan repayment, $5,000 for tax income. And so for us to apply, it's just one of those pain in the neck applications. The kicker is you're required to have a sliding fee scale in your clinics. And I don't know that we have a well-defined sliding fee scale, which should be part of a financial assistance policy. So the next application is like 6 months from the middle of November. And so for us to be able to apply 6 months from now, we have to get that sliding fee scale in place by the 15th of November. It's good practice for us to have this, whether we were doing the National Health Service Corps or not, so that people who are at 100% poverty get 100% discount. So as we try and recruit people, we would be taking into consideration their financial situations. So it's something we should be doing anyhow, but we can sort of coattail and get 2 birds for one, and as part of the National Health Service Corps application, and that's one that I know Lindsay is just dying to take up. So again, I'm assuming, and it doesn't cost us anything other than time, but I'm assuming that the light is green unless you tell me otherwise. Lena already mentioned USDA issues related to construction payments and the complications from the government shutdown. So I'm not going to have anything more to say there. CMS numbers update. We still haven't gotten our CMS numbers. I Daily was supposed to have a meeting with CMS today, and then they're supposed to be sending us a note. They were supposed to ask where we're at as far as getting our numbers. Because remember, we need the numbers so that we can go back and bill from September 16, and we need the numbers in order to convert to critical access. So until we get the numbers, we're pretty much on hold. We have the application pretty much ready to go. I mean, the end of month numbers, we'd want to update them, but we're ready to do the critical access application as soon as we can get those numbers. A couple of things for looking forward and in an effort to try and shorten our meetings, besides me talking less, is I'm going to suggest that we divide operation reports into a quarterly schedule. So rather than having everybody report every month, I'm going to suggest Lane reports 1 month, Lindsay reports 1 month, that sort of thing. So then you might have a little bit bigger report, but you only hear a quarter's worth. So I'm assuming the light is green on that one, unless you guys are heartburn with that. We're going to move to that schedule. Okay. And then Artie had talked about the board doing a limited number of job descriptions. So the ones that I would have, CEO, CFO, compliance officer, and then know that all other job descriptions are reviewed internally by the leadership team and involving the medical staff as appropriate. That's one. So just as you did with the press releases, you just had a statement in the minutes that all press releases will now go through the CEO when you're ready, and you can be ready tonight, or you can be ready at the next meeting if you want to. But I really think in order to take workload off of you, let us do most of the job descriptions. That's not something the board needs to do. And then in a similar fashion, I'm going to suggest that the board only review big organization-wide policies. So you had two policies tonight, FMLA and the medical staff. Medical staff is one that you should do. FMLA is one you don't need to do. There, we should create them, and I will, with your permission, I'll be presenting for you, but big policy. So there should be a big policy that talks about responsibility for creating a budget, responsibility for doing an annual audit. Those policies should be approved by the board. And then the how we operationalize those, you don't need to be involved in that. Same thing for HR. We should have a policy that talks about, we're going to have job descriptions. We should have compensation philosophy policy. Those are things the board should be looking at, not our year analysis policy. So that's also one that I'm going to suggest that the board say, we'll bring big organizational policies, medical staff policies to you, but otherwise we're going to deal with all policies. And I'm happy to write a policy on that if you want. So there's already been, Don talked about the Rural Health Transformation Program. So we had, as we discussed at our last meeting, we had our own brainstorming session. About 30 people attended. It was a really good session. And we submitted our list. I attended then the WHA sponsored session in Casper. And the update that we got just today was that the Wyoming state plan has been written by the Department of Health. The governor is now reviewing it. And so they're saying maybe tomorrow or the next day we'll see it. CMS apparently has made some changes. And it's not the simple application that Don mentioned that they thought it was in the beginning. It doesn't look like we're going to be able to edit the document, but at least we'll be able to review it. So assuming that it's not something that's deemed confidential, when I get it, I'll send it out to the board and medical staff so everyone can see it. Let's see. Oh, just, did you know we moved everyone up to the Heritage Home?
Yes.
Has anyone told you? I'm joking. I want to congratulate Don and all the people that were involved in that. That was really something, how well that came off. And then let's see, last thing, space in the clinics. So we've converted many exam rooms in the Pinedale Clinic into offices. We're sort of starved for office space. But what that means is that as we look at growing clinic volume, we are limiting our ability to have clinic exam rooms. So I have a meeting on Friday scheduled with Dawn. She's going to take me through the Sublette Center. I think that we need to move not just one or two offices, but quite a few offices down into the Sublette Center. And I'm going to suggest that administration needs to be part of that. Because if administration moves down, no one can carpet me about, wait a minute, why are you not doing it if you're making us do it? That's something I'm assuming that you're not going to have a lot of heartburn. We really want to position the clinic to have space to see patients. And so cleaning out some of the offices, because I'm assuming we aren't going to have the money to remodel the lab, CT, and X-ray spaces for a while. That's first where I wanted to go, but I think we need more space than that, number one. Number two, I don't want to spend money on that right now. So moving people down into the Sublette Center, I think that we can really do two things. One, we can address our office space needs, and we can give the clinic back some clinical space. So again, that's one I'm assuming is green, unless you tell me otherwise. And I want to have that done by the end of November. And so with that, in regular session, that's all I had for you.
Good, thank you.
One question on policies. I feel like we weren't approving all the policies. Did we have
We do,
Is there already a policy for that or some type of,
we do have a policy on policies.
okay,
That will be editing that policy on policies.
okay. We have that, it will just.
So example, ones that I think should come to you. So medical staff rules and regs and bylaws, hospital bylaws, a compensation philosophy policy, a financial responsibility policy that would include budgets and audits, global human resources policies. And so the example, we're generating a new administrator on call policy. That's one that I would tell you about, but I don't think you need to approve it. So, you know, the day-to-day policies like lab policies, those you don't even need to be told about. But something like administrator on call policy, or maybe a security policy, those would be things you should be informed about. But there's a really limited list, 12, 15, that the board really should be reviewing.
And that'll help us take steps along the path to get to board governance, right? Sort of. Yep.
Strategic plan. Yeah.
All right, thanks, Bill. Next section is old business. A, approval of payroll and bills.
I would make a motion to approve payroll and bills for the month of September in the amount of $1,453,497.68.
I'll second.
Moved by Kendra, second by Taylor. Any discussion or questions? Call for the vote. All those in favor?
Aye.
Any opposed? Motion carried. New business B, 6 invoices that are over $20,000.
I would make a motion to approve the invoices over $20,000.
I'll second.
Ashley, second by Taylor. Any discussion or questions? We'll call for the vote. All those in favor?
Aye.
Any opposed? Motion carries. Next is C, delegation review that we've been working on. In our packets, the original, and then we have section 6 through 11. Get there. And also Bill's proposed change. So we'll open that up for discussion. It's not an action item tonight. We're just continuing our discussion of our designation of authority.
So with your permission, I'll walk you through sort of my reasoning.
Go right ahead, Bill.
So I'll start with number 7. I think actually 6 last time was on the list. Because we had 5 and I grew it to 6. So starting with number 7, I see a big difference between contingency agreements and retained agreements. So contingency is when you don't have to pay unless you actually hire somebody. Retained is where you're paying them a monthly fee, and then there's a contract fulfillment balloon that's paid at the end. I do not like retained agreements. You're paying for something you may never get. And I like contingency. I know they will say, well, in the contingency environment, we're working for dozens of hospitals, not just you. In a retained environment, we're only working for you, and I would call baloney on that. They're working for everybody all the time. I don't believe that when they get a candidate that it's just ours. So I don't like retained. And so that's why I'm saying that contingency are preferred. And I can be pretty cheap on these. And so I'm saying that I would have authority to do contingency. If it's retained, I need to give the board approval. Because that's where I see the risk. Because these things can drag on for months. So you're paying this monthly fee and then you still have the balloon at the end. So that was my thinking on that. Employee benefit contracts. That's one that I think that those need to have. So when we're talking about, like we will later, employee health insurance,
Right.
that's something that the board really needs to sign off on. So we would make recommendations to you, but that's why I think that needs to be approved by the board. And number 9, this is the same theme as I had talked about before. I look at expenses that have been included in the budget differently than I look at non-budgeted expenses. So if we have already anticipated a contract, then I would inform the board, but I don't need the board's approval. I do have a threshold though of $100,000. And that's a pretty big number. And so once you get into that area, then I think the board needs to sign off on it. Maintenance agreements, for the most part, should be budgeted. So again, that's not something that I think the board needs to be involved in. But you can see, I say, agreements or contracts that have not been included in the budget and are more than $100,000 need to be approved by the board. So if you've approved a piece of capital equipment and it's a new piece, then at some point we're going to need to have maintenance agreement on it. That should have been discussed when the purchase was approved. So again, unless it's more than 100,000, I'm going to say you've already, in essence, approved it by purchasing the agreement. I mean, the equipment. So that's my thinking on that one. So managed care and service agreements. So the way that I wrote it was conservative, that I signed it after you approve it. I don't know, so I put this one in yellow. I don't really think you guys want to be reviewing payer contracts. And of all the kind of contracts there are, these are some of the driest ones. And when you get into the technicalities of reimbursement, it's not something that the board is going to have any perspective to say, yep, this is a good contract or not. So while I have it written that the board approves it, because I know that payer agreements are a big deal, it would be my recommendation that you not get involved and approve. So that's why I made that one yellow, so I wouldn't forget about it. Medical staff agreements, this is an external requirement that the board needs to review and approve contracts. So all medical staff contracts are approved by the board and signed by the CEO. And then grants. So sometimes, and I know some people would say, why wouldn't you pursue a grant? Some grants, there's such a low probability of us getting funded. And yet it could take a lot of work. So I have this threshold of $250,000 that, you know, things that are that big, the board needs to get involved. Stuff that's less than that, I don't think the board needs to. So again, it's just my perspective, trying to understand what I think of as more day-to-day operational things versus big picture. Because once you start going after $500,000 or $1 million grants, that's a big deal. And it probably ties to some sort of foundation related request as well. So check signatures. You can see my little yellow comments there. And so this one, the first comment is not to do with approvals, but just the process. Companies more and more are getting tired of paper checks. The check is in the mail. They don't like it. More and more it's electronic. So I think we need to move in the direction of doing electronic checks, whether it's exclusive or whether it's most of the time, but I think we need to head into that direction. And then you can see that I talk again about budgeted payments are part of a normal process. And here I'm throwing in CFO as well as CEO. And then unbudgeted, you can see the threshold that I'm suggesting. And the question of wet checks when there are wet signatures that are needed. I'm used to seeing you can have CFO or CEO and a board member. You can't have CEO and CFO. So you need to have one board member and then one, so it just makes it cleaner for you guys. Only one of you has to sign, and then only one. So then CFO and I both couldn't do a check. So that would be the idea on that one. And then you can see the threshold emergency purchases. So I'm suggesting, so I'm on 15, that by definition, an emergency purchase doesn't follow the normal approval process. Otherwise, it's not an emergency purchase. And so I came up with 96 hours. And where that came from was thinking in terms of a long holiday weekend. So if we had something that came up on a Friday and then the following Monday is a holiday, but we really have to get it done on the Friday, then I would contact a board chairperson or follow the chain of command. If I couldn't get Tanya, then I'd call you and say, this is where we're at. Because I don't think we always need to call an emergency board meeting. But sometimes by doing the notification, then we can say, if the board wants to do an emergency board meeting, this is what's going on. So I didn't include any dollar amounts there. If it's an emergency, then normal rules don't apply. That was my thinking on that one. And then capital purchases, I wanted to make sure, and I need to check with finance on this, our definition of what a tangible capital asset should be, it should be greater than $5,000 and having an expected life of at least 2 years or more to qualify. A lot of hospitals have dollar limits less than that. You want to have that number pretty high so that you can depreciate things more quickly or expense things more quickly if you can. And then we need to have a policy related to when a bid is required. And I don't know if that exists. If it doesn't, it will be developed. And then you can see again, including dollar amounts. I wanted to have bigger numbers, but I'm also sensitive that this is an evolution. So I would be comfortable with the numbers that I'm putting in here. So that's sort of my thinking on where I came up with my suggested numbers.
Just out of curiosity, do you currently handle capital purchases differently than an expense purchase from an accounting perspective?
So I don't know that.
Okay.
So what I will suggest is that we should have a two-step process. So as part of the annual budget, we should do a capital equipment budget. And so that gets things on the list. But then we have a schedule by quarter of when we plan to buy things. You can't buy everything all at once. But then when it comes up third quarter and we've got these things, we have to then go through and do another round to make sure we still want to buy that thing. So just because it got on the list in the first place doesn't mean it's a slam dunk, we're going to buy it. So I am going to recommend a two-step process. So if there are any other questions, I just thought it would be useful for you to understand sort of my thinking, my rationale.
Guess just one comment I would have or kind of questions around emergency purchases and I fully understand that there will be, occasions where something needs to be, but do we need, since it doesn't have any type of limit or anything on it, do we need to define what an emergency purchase is or to make that?
And we certainly could. So I'll give you a specific example that I faced in the past.
Yeah, perfect.
The tube for the CT machine. So when the tube on the CT machine goes out, you don't have a CT. Those things cost like $85,000. Now, if you have service contract, sometimes depending on why it died, service will cover it. But glass often is argued about in service agreements. So I've had situations where, and it always happens on a weekend, CT bulb goes out and I need to buy another one. That would be an example in my mind of an emergency. If it's something that isn't going to affect patient care, it's not an emergency.
Right.
Special order for medication, that might be another one that would be an emergency.
Could we list that in there, like the definition of an emergency purchase? Like
Yeah.
if it's not related to patient care,
Yep.
then it's not defined as an emergency. Okay.
So I'll take a swing at an emergency definition and can include that in an updated version.
Okay. And then also in the capital purchases, you have if there's a policy already exists, if not developed, will that also be in there?
Yeah.
Or provided?
Well, it would be a separate.
Right, yeah.
I think there is a statutory limit. Triggers a bidding process. We just have to do that number.
I like the changes.
I really like the changes. And I do like the idea of a CFO/CEO and one board member. Yeah, it very smooth. Or makes it a lot more simple. And go into electronic payment.
Especially because I don't know how that works for us, but you know, that those things can be generated to pay on the due date. So you're not, you know, we're holding on to our money as long as we can. Right? Is that how that?
But we really should be, so 30, a lot of the bills are net 30.
Right.
You really want to shoot for 35 to 40. Because a lot of times you don't get a penalty yet.
Mm-hmm.
And those couple of extra days, especially on big ones, can make a difference.
There's a lot of companies that they push that.
Play that game.
Yes.
Yeah. It's all about cheating within the rules.
I know my company, I approve an invoice, but that check did not go out until that invoice is due.
Yeah,
can-
and I think,
I can comment on that, Ashley. I think in most cases, standard is if the ACH is or the transfer is initiated today, then it will naturally be tomorrow. Otherwise, it's known as a same day transfer, and that same day transfer always carries a cost.
mhm. I don't know your transfer.
Gotcha.
The
So
other
it's not,
Sorry.
I was just gonna say, it's not then necessarily set up to pay, you know, when it's due as opposed to when it's received.
Got you. Okay. I wanted to just comment very quickly on two other things quickly. The one thing is the CapEx budget. Just to, you know, I completely agree with Bill. What we're doing, all of our hospitals now, when the annual budget is put together, and there's one line item global figure for CapEx, what we are asking all of our hospitals and finance departments to do is to actually produce a line item for all the capital expenditure, which the board also approves. So they know exactly what that global number is in terms of a breakdown. And then the other thing that I wanted to mention was with regards to contingency and retainer that Bill was talking about. Completely agree with him there as well. You know, we're placing on average, as you know, I oversee our staffing and recruitment division called Impeccable. We place somewhere in the region of 25 C-level execs every single year, CEO, CFO, and chief nursing officer. And we are not doing any retained search. I don't think we've done any retained search for probably about 2 years, 2.5 years. So I just wanted to mention that as well.
Speaking of the budget, we just talked about looking at the budget and revising that. Are we looking to make these changes before we have that? Would that be considered, I guess, from our perspective, if we're gonna go ahead and, you know, go forward with these changes, but knowing that the budget's gonna be revised, where does that put your guidance on reviewing these? I
I
guess,
don't think you need to tie the two together.
okay, don't tie the two together.
Yes.
Okay. Guess that was my question.
thank you for making. those
Yes.
recommended changes.
Yeah, for the two.
Everybody good with questions? And
If I'm good.
Leads the delegation of authority.
I'm good to do that. I mean, we passed
11, right?
11. That's good. Maybe next month we take some action.
Yeah.
Pretty good. New business is next, and we have section A. Head of staff bylaws revisions. Those are for approval, so they're action.
To approve the medical staff bylaws, the proposed changes.
I'll second.
By Kendall, second by Ashley. Any discussion? Call for the vote. All those in favor? Any opposed? Motion carried. Item B, or conversion to critical access hospital. It's resolution 16, number 16 of the year 2025.
So I can speak to that one briefly. So it is a requirement of the application that we have direction from the board to actually convert to critical access. And that's what this resolution is designed to do. Lena has been actively involved in the creation of it. And I think she's still on the line, but speaking for her, she would be part of recommending this resolution to the board.
Make a motion to approve conversion to critical access hospital resolution number 16-2025.
I'll second.
By Ashley, second by Taylor. Any discussion? We'll call for the vote. All those in favor?
Aye.
Any opposed? Motion carries. Item C, our health insurance benefit discussion. Turn that over to Bill. I think we also have a Taylor associate on too. Then you for it. Good.
So we have Tiffany Monk from Teglers, who we've been working with to put together our benefits package. And Tiffany, would you like to talk a little bit about what we have come up with?
Hello, everyone. I hope you're doing well. I wasn't sure if I was going to be speaking tonight, but I can say a little bit if you'd like. Did you guys have any handouts or anything put in your packet for this week?
Yes, they have the 30-page slide. If you want to just
Oh,
go over it in a couple minutes. We're like,
well, hold on just a moment. I don't have my slide deck up, so let me.
they have it in front of them.
So essentially what it's turned out to be is that the health fund has had a very positive performance over the year. And it has built up a nice clearing surplus, which will be shared back with the district at a point when the run out for the policy has been completed. So that will be in early 2026. And at that time, we will look at what reserves are left over and make some plans for the future in terms of funding claims accounts that would set the district up for traditional self-funded policy. Hold on a minute. Can you get her to quit fussing me? Just. And I'm sorry, I've got my little one following me around singing songs here. So with that, we really focused on, getting the health plan in the best position for the new year with Blue Cross Blue Shield on the current product line, which does keep the risk point at a level that is very budgeted and consistent. And with that, we've been able to get some really good claims reductions and health plan reductions that actually reduced the cost of the health plan. And within that, we were also able to pull some additional levers within the plan to yield an even better cost. So with that, we were able to keep the same plan design at a reduced budget of 5% on premium. And then in the effort to reduce the budgeted amount for HRA, which is the health reimbursement arrangement, provided to employees to help offset their costs for health services under the plan. We were able to position a gap plan that would provide the same coverage at a much lower budget point. And this, in combination with the lower rates, yielded a very nice decrease in cost. So in total, with all changes that were applied, it put the health plan in a position of about 14% decrease. So within the slide packet, it's going to go over a little bit more about each comparison that we had done. Because just looking at the straight across renewal, what if we do the same thing next year? And then what if we move down the HRA liability? All the different scenarios still proved that adding in a fully insured gap plan to fulfill what the HRA is currently doing was a more consistent approach to providing healthcare to the employees at the same as what they're experiencing now. Sorry, we were carving pumpkins and my 4-year-old is really trying to get my attention. So, just kind of kicking it over to the board, if you've had a chance to look at the slide deck, what questions might stand out to you and based on what you were able to review?
Tiffany, if I could jump in before you ask questions. So
Yes,
when we
absolutely.
started with this process, one of the things we were hoping to accomplish was moving to a self-funded. We decided now wasn't the right time to do that. We need to save money, and doing a self-funded program would have taken all of the money we're going to get to create the reserve fund, plus we would have needed more. And so we decided now wasn't the time for that. We're positioning ourselves still so that a year or two from now, we can move in that direction. And so setting aside the money that we have as sort of the down payment on the reserve fund, we think makes sense. But right now we need the savings. But we wanted to do it in a way that didn't negatively impact the employee. So we tried to keep the plan design pretty much the same. We haven't raised rates for the employees for quite a while, and our rates are quite low. So you'll see very small, so from $25 to $30, or for a family, $150 to $175. So increases, but what I would describe as modest. And I think we need to continue that so that we can get a little bit more normal as far as what our rates are. The HRA was the thing that we spent a lot of time talking about. So our experience has been about 185,000 is what we've been expensing for the HRA, but the liability was another 800,000 potentially. So if everyone in the organization got their full HRA benefit, it would cost us almost $1 million. So we were budgeting. So for this cycle, I think it would have been right around $200,000 is what the estimate was. But there was an unfunded liability, if you will, of another 800,000. That just scared me to death. And even if it's only 100,000 of that, that's still 100,000 we haven't budgeted for. So what we were able to do Tiffany found us a GAP plan. So it's a second insurance. And so when an employee presents to the hospital, you would give them two cards. You would give them your normal Blue Cross card, and then you would give them the GAP card. And then they would bill both of them. So it simplifies it for the employee. So rather than having to keep receipts, turning them into us, and then first having to pay and then getting reimbursed, this all gets billed through the insurance company. And so the GAP benefit is the same as what the current plan design is. But we have a single number. We're budgeting for this insurance product, and then we have no additional liability. So we thought that was really a good compromise, that it saved us from having to cut the HRA for employees, which was probably my first inclination, but then protect us as far as this big liability out there. So just for comparison, Thermopolis has a 19% increase in their insurance. They budgeted 10. So for us to show a savings of, what is it, Lindsay, around $380,000? I mean, it's just unexpected. And so it would be our recommendation that you would accept the proposal that we've made, that we do these modest rate increases for the employees, that we move to this GAP program for the HRA benefit. That would be our recommendation to you. Now you can ask your questions.
My question was just gonna be, what exactly do we need to approve?
Yes.
In terms of because in here, like, there's a couple of different options, and you know, the last slide has some final decisions, and so I wasn't sure, like,
What's the last stuff?
okay.
Yeah, this is. You got one.
Hey, I can speak to that. On slide 32, there's a final medical review comparing the options, and the fourth one on that page would be the recommended option in the future total cost summaries, following on slide 34 and 35. And then 34 and 35 are also including all ancillary benefits, which are dental, vision, which is 100% employee paid, but just illustrating that here. And then the Lincoln life and disability packages as well. So when you're looking at the total budgeted cost with all of the changes Bill referenced, that's the estimated 2.47 million for the combined total cost summary for the benefits plan renewals, and then just ultimately seeking approval to transition away from the current HRA to the GAP policy. But everything else would remain the same.
And it's also important for you to know, we increase the number of projected covered lives a little bit to reflect the growth in the organization. So the number 135 or 138, something like that, is a little bit higher than what we actually have today. So we were trying to anticipate a few more covered lives as we grow in the number of employees.
And for your reference, it's page 28 on the slide deck that we showed you.
Okay.
And so that is basically capturing what you're going to be hopefully recommending or approving, sorry.
We need to include that dollar amount in the motion, or are you just approving it as presented?
Proposed option.
Very good.
I would make a motion to approve the employee health insurance benefit package as presented.
I'll second.
Been moved by Ashley, second by Kenda. Any additional discussion? Call for the vote. All those in favor? Any opposed? Motion carried.
Excellent. Thank you.
Thank you. That's a lot of, thanks you to the team.
I think they did a great job. And something I thought was interesting, she said we would need about $523,000 in claims reserves to start a self-funded program. So remember that we can,
I think we get enough of that, don't we?
really, only half?
Yeah, we get enough of that.
Oh, okay.
And so that's one of the reasons we eventually want to go to self-funded, because then any access like that, we keep it all. But in the current configuration, we get half of it.
Okay.
So it was just shy of 300,000 that we'll have as the down payment in the reserve fund.
To go towards, but didn't she say we would need in a claims reserve account, like 500,000?
Yes.
Yeah.
And that's where we didn't want to spend that much money
Right.
now.
Right, just for future though.
Yes.
It was just, that wasn't as much as I thought it would be, honestly.
Yeah.
I thought it would be more than that.
Future aspiration.
That's right.
You do.
That's what we need.
Someday.
Extra 500 grand.
And I wanted to make a comment about Tiffany's work with Tegler. 3 years ago, she did a lot of negotiating, the team did a lot of negotiating. So we had a lot of set rates. And so it just very thankful for that, foreshadowing, or that wherewithal, because it has really helped these numbers tremendously. And so even though we're up in the annual billing premiums, Tiffany's just done a really great job, and looking forward to keep working with her.
Yeah, 14% savings.
Yeah, that's huge.
Yeah, especially in this climate.
Thank you, Tiffany.
Thank you so much. I really enjoyed working with the team and appreciate the opportunity.
Go chase your 4-year-old now.
Good luck.
I will. Harvard pumpkin. So I'm curious what I'll find when I get back, but I hope y'all have a good night.
You too. Thank you.
Bye.
Next item is Kelsey Wagner contract.
So I've met with Kelsey and we've renegotiated a renewal to her contract. This contract uses our recently revised template. It includes compensation that is consistent with current MGMA as well as other recent hires that we've done. So we're looking at internal equity to make sure that that's consistent. It includes similar benefits, medical staff level benefits, like continuing education, student loan repayment, those sorts of things. There is no sign-on because it's a renewal. It has been reviewed and approved by legal, so it would be recommended to you that you would approve this contract.
Does anybody have this contract? Because I don't
No.
have it.
But remember, we're using a different approach with contracts
So we're not looking-
where
You're not
you're
looking
not,
at it.
you're not.
Okay, did that happen in the week that I wasn't here with those contracts?
This is the second time we've done this, so we did
Okay.
this with Christie Collett's contract as well.
Okay.
To approve Kelsey Wagner's contract.
I'll-
Quick and a second by Tim. Any further discussion? Call for the vote. All those in favor?
Bye.
Any approved, any opposed? Motion carried.
Thank you.
Item E, employee recruiting assistance incentive program, whatever. It's on the paper.
So can you pull that up on your screens? Can you see that?
Mhm.
Okay, so there are a couple of things that I want to talk about to explain this. So I had already told you that we had gone through and we had looked at different levels of positions in the organization and defined the incentive that the referring employee would get, and then you can see the schedule. Some of them are spread over 1 year, some 2 years, some 3 years, depending on the size. So if the employee were to leave before the end of the incentive, then everything goes away. They don't continue to get it when the person leaves. But there are two specific questions that I wanted to talk with you. So senior leadership talked about this. There were two things that I wanted to get your input on. So under the general rules, number 2, members of the senior leadership team and leadership team, so that would be department directors, department managers, are not eligible for incentive payments. So I've seen, that's the way most organizations do it. I have seen some organizations, though, that will allow leadership to receive incentives in the case where they are referring outside of their department. So if I'm the lab director, I don't get an incentive if I find a lab person, because that's my job. But if I'm the lab director and I find an X-ray tech, I can get an incentive for referring to X-ray tech. So I just wanted to get your input on which you think is going to be the best way to do that, just to say, nope, leadership recruitment is part of your job, or it's your department that you're exempted from. So I'd be interested in your feedback on that topic.
I would say leadership and senior leadership are not eligible. I think recruiting is part of it. That's my opinion. That's how I've seen it with other companies before. Yeah.
Others?
I was actually kind of thinking different, that, you know, I agree if it's within your department, that is your job, but if it's outside of your department. And I think in terms of like directors, you know, I mean, no offense, but I don't think the CEO gets it. So maybe defining what that level is, you know, because really everything's under you.
Well, and I guess that's where I was thinking, like with the COO, like over operations, or the CMO, it's kind of still in that maybe at a high level.
So you could easily say senior leadership is exempted.
Okay.
Leadership is exempted from their department.
That's fair. Yeah,
I like that.
yeah, I do like that, like the blended.
Okay. Then the other one that I wanted to have you talk about is under the section, the new employee number 2 may not be directly related to the referred employee. So if I refer one of my kids, well, don't use me because I never am going to be eligible. But if Carrie were to refer one of her kids, would she be eligible for?
Oof. It's gonna be tough in a small town.
That is hard. It seems like a conflict of interest kind of, but yeah,
Yeah.
you're right. I mean, small towns are hard.
Thought it. Her daughter is a dynamic CT tech. Like that.
Yeah. No, but
It's just, it's
kind of issues, right? Because senior leadership team threw this one around and had different opinions. So that's why we wanted, before we start doing this, we wanted to get your thoughts.
They have a qualified family member, they shouldn't be penalized because it's a family member. I don't know.
But so the argument in favor of letting them have it is that they could say this is a great place to work. I mean, they really could tip the scales on that person coming. And so I can see the case that they should not be exempted. That's a double negative, isn't it? They should be eligible. Those were the only 2 things. So, and I'm happy to make those 2 changes, but the rest of it, you can see incentive payments. We prorated. PRN is 25%, part-time is 10%, full-time is 100. You can see that they have to be in good standing, no discipline. They have to tell us before they apply. So this isn't anything that we're ready to, oh, by the way, so, and I'm sure we're still going to run into that. If normal withholds would apply, payments start right away, and then I already mentioned if they quit or get fired, then no further payments. Someone who has been here, left, and is coming back in the same position doesn't get it. 2 years is our threshold. So if you've been gone for 4 years, you still could be eligible. But if you left as a CNA, but you're coming back as an RN, then we see that as different. And then I have to do an entire quarter. So if you're comfortable, I'm going to assume that with the changes that we've discussed, unless you tell me otherwise, this is green and we can start. I think this is going to be received really well by the employees. Rather than paying recruiters,
Yeah.
pay them.
I'm good with green.
Will there be a policy of what the employees are supposed to do for the?
Yeah.
Perfect.
Yep. I just want to ask you.
And like very clear guidelines.
Yeah. Okay. Thank you.
All right, so I need Bill.
So that's all I need. Yes.
Thank you. Moving on. Job description discussion.
So we already touched on this and I expanded it to be policies and procedures, but the reason this one is on the agenda is because we had teed it up at the previous meeting. So if you're comfortable saying that only a limited number of job descriptions really need to come to the board, then if you just have a statement in the minutes like we did before with press releases, then we get it done.
And we discussed CEO, CFO, compliance, COO, CMO, and then the rest would be.
Yeah, pretty much the O's.
Yeah, all the O's.
But beyond the O's,
Everything.
it really is.
Yeah, I'm fine with that too. It doesn't say there's an actual action.
No,
Just
so
a statement.
just be a statement in the minutes saying
Okay,
the board agreed with the CEO's recommendation that only O job description.
what he said. It's in the minutes.
Okay, good, thank you.
G is our freedom of information request this month.
One quick, the one that we had last month, I believe we were gonna receive a copy of, and I don't think we ever received.
I did not.
You were supposed to
Yeah.
ask Lena if you wanted it and she would send it.
Oh,
We did. We actually.
I thought we did during the meeting.
Yeah.
We can get with you on that later then, Lena, or?
Yeah, it was actually sent, but I wonder if it didn't go through due to size or something, because it was sent the day that it
Oh.
was responded to. So let me look into that. I'm glad you mentioned that.
Thank you.
Yeah, I'm glad you mentioned that.
What, the minutes?
Yeah, we can do, I'm gonna say it about, we're gonna circle back.
Oh, I have it.
We can approve the minutes.
It's not part of the
from,
consent
September
agenda.
24th. No, yeah, the minutes.
I wanted that we approve meeting minutes for September 24th and all of the executive session minutes,
Uh,
including September 24th, October 5th, October 8th, and October 15th.
I will second.
Move back into second by action. Any discussion? Call for the vote. All those in favor?
I,
Any opposed? Motion carried. Next, we do have an executive session. And the list is there on our agenda.
I would make a motion to go into executive session, for the purpose of personnel, real estate contracts and legal.
I'll second.
Been moved and seconded. So your knowledge, we don't have any action after executive or do we?
No, I don't have it.
Is I know of no action after executive, so I'm gonna tell the folks that are online, we do not anticipate any action after, there won't be any action after. So as we adjourn the executive session, you're welcome to depart the Zoom and enjoy the rest of your evening. It's been moved and seconded, all those in favor?
I.
Any opposed? Motion carried. I'm in a recess.
I'll have it.